Hi, my name is Connie O'Clarnis and you're watching the video on the characteristics of constant exotropias. Okay, let's go back to the flow chart which we discussed when discussing the overall classification of exodeviations. And what we see here is that an exotropia patient who has a primary deviation can have either a constant or an intermittent deviation. Now we've discussed intermittent, so our focus now will be on the constant exotropia. And for this video, I've also given you a further subclassification where you could actually define the patient or diagnose the patient as either having an infantile constant deviation or an acquired constant deviation. Now, we're not only going to discuss primary constant exotropias in this video, we're going to also take the opportunity to discuss secondary, consecutive and residual deviations. And the reason I'm doing it in this video is that often these deviations are also constant. They're not always. The consecutive and the residual deviations could potentially be intermittent deviations. Secondary deviations are generally constant. Okay, let's go back to that subclassification I just mentioned a moment ago, where you could either indicate that the patient has an infantile exotropia or an acquired exotropia. An infantile exotropia is one that develops under generally the first 6 months of life. Now later we'll start discussing a condition called an infantile esotropia. And in discussing this condition, we'll see that it's associated with a variety of features. Features such as late nystagmus, DVD, which is dissociated vertical deviation, and a number of other clinical features. The infantile exotropia is very similar to the infantile esotropia, but is extremely rare as compared to the infantile ET. So what we'll do is we won't discuss the infantile XT in this video, but we'll come back to it when we discuss the infantile esotropia, and then we'll have a better understanding of what we see in this particular condition. Now moving on to the acquired or later onset, these are obviously patients who develop an exotropia after that infantile period, so that first 6 months of life or even after the first year of life. And often these patients are patients who had an intermittent exotropia who have decompensated. So the intermittent exotropia became more and more frequent and eventually became constant. Now I just want to take you through the definition of these 4 types of exodeviation, the constant, secondary, residual and consecutive deviations, and talk about what we expect on a cover test result for each of these. So let's start off with constant. Clearly what we expect here is to see a exodeviation that's there all of the time. And so here we have a cover test result where we've got a left exotropia at near and a left exotropia at far, and we have a measurement here of the deviation. Now we see that there's only a 5 diopter difference between near and far, and so we could also further say that this is a basic constant deviation or a primary basic constant deviation. So if there is a near distance disparity, you could actually go further to indicate that it's a divergence excess or a convergence weakness exodeviation. In terms of the secondary deviation, here we have an exotropia that develops secondary to a sensory defect. So there's a pathology there that's obstructing BSV, and therefore a deviation occurs. So what we expect here is that there will be some pathology, and then we'll have again a constant manifest deviation at near and at far. And again, for this patient, it's basic as it's 25 diopters at both distances. Now, with the residual and the consecutive deviation, these are deviations that are post-operative in nature, generally speaking. So with the residual, what we see is that we have an exotropia at near and far before surgery, and then post-operatively, there is still a exodeviation, and it might be, in this instance, smaller than it was preoperatively. So what we have is a residual exotropia. And in this example that I've given you, or the cover test result here, it's a residual constant exotropia. For the consecutive, what happens in this instance is we have an exotropia post-operatively, but the deviation was actually an ESO prior. So we see here preoperatively an esotropia of 20-25, and then post-operatively there's been an overcorrection, in which case we now have a left exotropia of 5 diopters. So in terms of etiology of these conditions, I've listed here some of the etiologies that you'll come across in your reading. I don't want to go through all of these in detail, but I do want to highlight a couple of points. One is in relation to the secondary deviation. Depending on the age at which the deviation develops, this will determine whether the secondary deviation is an exo or an eso. Most secondary exodeviations occur in adults, and that's because there is a reduction in the convergence tone. So if there's a disruption to BSV, more often than not, it'll be an exodrift that occurs at that point. On the other hand, with children, because their convergence tone is relatively strong, these children tend to end up with secondary esodeviations. However, for patients where the pathology has occurred at a point in time where there isn't a strong convergence reflex, and this is really only in a newborn, then an exodeviation will develop. The other thing I want to point out is I've indicated there that you could end up with a consecutive exotropia that's due to an optical overcorrection of an esotropia or optical correction of an esotropia. What I mean by that is that when we give a hypermetropic correction to an esodeviation, we could actually end up giving the patient an exodeviation with that correction. So you may end up relaxing the accommodation of that patient to the extent where you reverse the deviation, make it a consecutive exo. So just be aware of that. More often than not, we don't use the term consecutive for optical correction, but it is worth knowing because some individuals may refer to it in that way. In saying that also, you could do the same with residual. If you have an exodeviation that's smaller with a myopic correction, then you could end up saying that this is a residual exo with myopic correction. Okay, and finally, I just want to go through some of the key findings that we expect in patients with these deviations. So for the constant deviation, we know that because that deviation is there all the time, if the individual is young and is or has the exotropia during cortical plasticity, then we expect amblyopia to develop and the patient will lose their binocular functions. Now again, depending on the age of onset, there may or may not be the opportunity or the potential for binocular functions later on. Now in terms of secondary deviations, these are constant deviations. And now not only do we have the strabismus, but we have the pathology that's interrupting binocular single vision and influencing visual acuity. So generally visual acuity will be poor, and it will be poor because of the pathology, and if the pathology occurs during cortical plasticity, there will also be amblyopia present. In terms of binocular functions, clearly they're going to be absent because this patient has pathology that's interrupted BSV, which is why the exodrift has occurred. The other thing to note here is that patients who are blind will often show nystagmus as well. In terms of residual and consecutive deviations, these are a little bit more difficult to describe because you're talking about a post-op outcome, which is dependent on understanding what the deviation was preoperatively and the age of onset of that deviation. Generally, if we consider that many of the residual and consecutive deviations are from constant pre-op deviations, then we know that for that visual acuity, amblyopia will be present if the deviation was there during cortical plasticity, and for the binocular functions, potentially they will be absent. And finally, with the consecutive deviation, I mentioned here that the patient may experience diplopia. The reason for this is we've actually shifted the CIP from the nasal retina when it was an ET to the temporal retina when it was an XT. And therefore, post-operatively, because you move the CIP to temporal retina, potentially that area is not suppressed and therefore the patient will experience diplopia. Okay, that brings us to the conclusion of this video. Thank you for watching.